Good evening. I'd like to thank Boehringer for inviting me to present this talk about how to protect lives using sodium glucose transport inhibitor, the cardiovascular and CKD protection by empagliflozin. This is an industrial symposium. Let me start by saying that cardiovascular risk in patients with type 2 diabetes are extremely high. And that's to say, patients with diabetes and cardiovascular disease, they have 12-year less life expectancy than non-diabetic. And if they don't have cardiovascular disease, they have 6 years less life expectancy than in patients without diabetes. And so diabetes can be seen as a cardiovascular disease, which occur inevitably in patients with type 2 diabetes, especially after a long time of exposure to abnormal blood sugar. And it's not only stroke or heart failure or acute MI, coronary heart disease, but also diabetic kidney disease and peripheral arterial disease. They all should be considered in patients with diabetes. And cardiovascular disease is the #1 killer of patients with type 2 diabetes, as well as in patients with chronic kidney disease, as we all know. And so preventing or decreasing cardiovascular mortality should be a prime target in patients with diabetes. And patients with diabetes and at least one other cardiovascular risk factor or target organ damage should be considered a very high cardiovascular risk. And despite receiving cardiovascular standard of care that includes antihypertensive, antidyslipidemic, RAS blockade, antiplatelets, in patients with type 2 diabetes and established cardiovascular disease, there's still risk and need for additional cardioprotection. This is the residual risk of all the study that included statin, ACE, ARB, and aspirin, as well as anti-diabetic medication. That's to say, we need to reduce cardiovascular morbidity and mortality in patients with diabetes. So can we do that? Can we address this effect? We know that in a STENO2 trial in type 2 diabetes, in which they targeted not only blood sugar, but also blood pressure, lipid, exercise, smoking cessation, have resulted in significant improvement in the primary outcome. And after rosiglitazone was stopped or got its black box by the FDA, all anti-diabetic medication were required to have a cardiovascular safety profile. And that's why they started by the DDB4 that was at that time, and then the sodium glucose transport inhibitor, GLP-1 antagonist, all of them were required to have this study. And the EMPERIG study by empagliflozin have showed for the first time an additional cardiovascular protection by an anti-diabetic medication. And this study is a well-designed randomized controlled trial that included 7,000 patients from 42 countries, followed for at least 3.1 years. 95% of patients are on antihypertensive medication, 81% receiving lipid-lowering drug, and 89% on anticoagulant or antiplatelet, and of course 98% of patients are using other antihyperglycemic medications. Most patients are receiving ACEs or ARB for hypertension, statin for dyslipidemia, and aspirin for antiplatelet. In the EMPERIG study, only 35% of patients have no previous atherothrombotic event. That's to say, 65% of patients have established cardiovascular disease. And that's why the result was astonishing. For the first time, with anti-diabetic medication, there were 38% reduction in cardiovascular death, and also 35% reduction in heart failure, hospitalization for heart failure. And also, it showed significantly reduced relative risk of incident or worsening nephropathy. And again, this is the first time an anti-diabetic medication showed renal protection. And the number needed to treat patient to prevent one cardiovascular event is 30 patients with simvastatin for 5.4 years, 56 patients in ramipril for 5 years, and only 25 patients for 5 years with empagliflozin, and 98 patients with liraglutide for 3 years to prevent one cardiovascular event. Comparing cardiovascular outcome trials with different sodium glucose transport inhibitor, the empagliflozin, the EMPERIG study, the DECLARE with dapagliflozin, CANVAS with the canagliflozin, we'll find that cardiovascular death only reduced significantly in the EMPERIG study if we compare it to the DECLARE study and CANVAS study. All-cause mortality also only significantly reduced in EMPERIG study if we compare it to the DECLARE and CANVAS study. While hospitalization for heart failure in different sodium glucose transport cardiovascular outcome study was almost similar. There is the same reduction of hospitalization heart failure in EMPERIG versus DECLARE and CANVAS study. So empagliflozin was the only anti-diabetic agent succeeded significantly to reduce cardiovascular death in type 2 diabetes patient in dedicated randomized controlled trial. Primary endpoint was achieved in EMPERIG and CANVAS. Cardiovascular death only reduced in EMPERIG, and all-cause mortality only reduced in EMPERIG study versus the other. And in the ADA-ASD guideline, starting from 2018 through 2020, sodium glucose transport inhibitor and GLP-1 are the preferred anti-diabetic medication in patients with chronic kidney disease and in patients with atherosclerotic cardiovascular disease. However, in patients with high and very high cardiovascular risk, it is recommended by the ADA-ASD guideline to use empagliflozin or cana and or dapagliflozin. These two are not present in Egypt in patients with very high cardiovascular risk, and to use empagliflozin alone from the sodium glucose transport inhibitor in patients with type 2 diabetes and cardiovascular disease to reduce the risk of death. And afterward, if we overview the major recommendation that recommend empagliflozin after the EMPERIG outcome trial, we'll find that in the Canadian, in the ADA-ASD, the American Diabetes Association, the American Association of Clinical Endocrinologists, European Society of Cardiology, and the American College of Cardiology, they all recommended using sodium glucose transport and empagliflozin to reduce major cardiovascular event, to reduce mortality, to reduce cardiovascular death. Also, the ERA-ELITA and KDIGO guideline have now a guideline for diabetic kidney disease recommending the use of a sodium glucose transport inhibitor for cardio as well as nephroprotection. So EMPERIG study was a randomized controlled trial, and EMPRISE study was a real-world study. We know that cardiovascular risk in diabetes affect 1 in 3. In the EMPERIG study, 2 of 3 patients have cardiovascular disease, while the EMPRISE study have included patients with and without cardiovascular disease, and it compared the outcome with the DDB4 use. So this is a real-world study, 5-year study, over 200,000 patients was included, comparing empagliflozin versus DDB4 inhibitors. And almost 17,000 patients was included in each arm of the study. And the result of the EMPRISE study comparing empagliflozin to DDB4 reproduced the same outcomes, the same cardiovascular mortality reduction like in the EMPERIG study, and showing that treating this patient with sodium glucose transported have better cardiovascular outcome than even with the DDB4, which are safe for the heart. Hospitalization for heart failure were also reduced in the EMPRISE study exactly like in patient on the EMPEREG trial. The study also showed that using 10 mg or 25 mg both significantly reduced hospitalization for heart failure, and this is a real-world study. In EMPEROR study, which is again a randomized controlled trial just published in the European Society of Cardiology 2020, a few days ago, 3,700 patients were randomized to either using empagliflozin or placebo, and it showed that the time to cardiovascular death or hospitalization for heart failure was better in patients receiving dapagliflozin than in patients receiving placebo. Also, hospitalization for heart failure, either first time or recurrent heart failure, was reduced in patients receiving empagliflozin versus placebo. One very interesting outcome also, that the slope of decline in GFR was slower than in patients with placebo, and there were significant reduction in progression to end-stage kidney disease with empagliflozin, again like the EMPEREG study in the EMPEROR reduced trial. And the renal composite endpoint was significantly reduced in patients receiving empagliflozin versus placebo. And so the conclusion of EMPEROR study, that the primary endpoint, which is composite cardiovascular death or heart failure hospitalization, was achieved significantly lower. First and second endpoint, which is first and recurrent heart failure hospitalization, was significantly achieved. And secondary endpoint, which is the slope of decline GFR, also was significantly achieved in EMPEROR study. And that's why the KDIGO guideline that will be published this year, this is the draft, are recommending using sodium glucose transport inhibitor in patients with GFR up to 30. When the patient reaches GFR of 30, you do not initiate sodium glucose transport inhibitor. You may not stop it, but you cannot start it or initiate it if the GFR is 30. And this is an extension of what was, we believe that we can use it GFR of 60 or 45. Now, we can still use sodium glucose transport inhibitor up to GFR 30, together with metformin. Again, they extended the use of metformin with reduced dose till GFR is 30. And afterward, we can use other antidiabetic medication. So what about using combination therapy, EMPA and metformin in a single tablet? Using either 5-850 or 5-1000 twice daily, or 12.5-850 or 12.5-1000 twice daily, have achieved the target. And this is a study design of using combination therapy, fixed combination therapy with EMPA and metformin versus using fixed combination therapy, one tablet of empagliflozin with metformin have resulted in better A1C reduction and better body weight reduction versus using each alone. So to conclude, the EMPEREG outcome study have shown that there is a relative reduction of hospitalization of heart failure was reduced by 35%. And the interim analysis of more than 35,000 patients in the EMPRISE, the real-world study, showed that empagliflozin was associated with 49% relative risk reduction of hospitalization to heart failure compared with DDP4 in patients with type 2 diabetes. EMPRISE, which includes 3/4 of patients without cardiovascular disease, showed that the effect of empagliflozin on hospitalization of heart failure was consistent in patients with and without cardiovascular disease, and this finding complement the result of the EMPEREG outcome trial and should be translated into routine prescription of sodium glucose transport inhibitor and empagliflozin in patients with and without cardiovascular risk, and also in patients with CKD to prevent progression to end-stage kidney disease.